Good morning, good afternoon, good night from wherever you are watching us. It is an honor for me to share with you again one of our surgeries here in China. We are in northeastern China, Dalian City. Today I am performing super mini Pcnl with my teacher Huawei. This patient is 46 years old and have 2 stones in left kidney, one in lower pole and one in UBJ area. We first performed rigid rotoscopy and we push the stone to the kidney. Now we are doing left kidney SMB. In China, we never use fluoroscopy or CM. All our surgical practice in urology, endourology, we performed under ultrasound, especially Pcnl. We use ultrasound for puncture, and we use our feelings and mathematical equations for dilatation of the kidney. Now, as you can see, we are in the system. I am sorry that I didn't record the ultrasound for this case. I hope next case we will record the ultrasound and the puncture at the same time. Now we put the guide wire, stiff guide wire. If you have stiff guide wire in the system, so it's rare to lose it. Now, when we remove the needle, we should measure. We must measure how deep is our needle, because as you see now, my teacher is using his hand to measure the depth of our needle. When you know the depth of your needle, you can dilate the same depth of that needle, so you will not get over dilatation and you will not perforate the backside of the kidney. So, but the kidney moves. Sometimes you will underdilate if you use this technique, but underdilatation is not a big deal for us. It's not a problem. In China we say yin jian wu shen, which means the success is in underdilatation and not over dilatation. So we mostly underdilate rather than over dilating the kidney, because if you overdilate, you will get perforation and the patient will bleed and your vision will be compromised and the success of your surgery will be less. Now we dilated 10 French with that the blue plastic dilator, and now we are putting our 14 French renal sheath, access sheath. As you see now, my teacher is using his measurement of 6 centimeter depth of the needle. So he feel that he entered the renal capsule. At the same time, he push the access sheath. Now we are not sure that if we are inside the system or underdilated, but we are sure that our guide wire is inside the system because we've seen it on ultrasound, our guide wire. But now we are getting urine coming out, so maybe we are in the system. So we first watch it and we get that we are in system, and then we have removed the guide wire. Now we are preparing the suction and the water pump. In SMB, most of time we put our water pump in the sheath and not in the scope. As you see now, I'm holding the scope. We never put the water in the scope. We put our water in the sheath because the scope is 7 French, and we will use laser 550 laser. So if you put water in 7 French scope, and the working journal is very small, so your water pressure will be less and the vision will be bad, and your surgery success will be less. So now we open the water, locate the kidney if there is any problem, any perforation, and then see the stones, and then start treating the stone. As we said, the stone, one of them is in the lower pole, which is 1 centimeter. The other one was in PUJ area, but we push it to the kidney, so it is in the lower pole. It came migrated to lower pole, but now we are searching the position of the stone. Here is the middle pole of the kidney. Our puncture, I forget to tell you, our puncture was in lower pole, posterior lower pole. In the kidney lower pole it is posterior and anterior, while in upper pole it is lateral and medial. So we entered posterior lower pole calyces. So stone is here in anterior pole of the lower. So now the stone is migrated to the UBJ area. Go back to renal pelvic. This area, treating the stone is challenging because you must careful that this stone not enter the ureter, because if it enter the ureter, you cannot use the laser inside the ureter, otherwise you will perforate the ureter. You will burn the ureter, and the patient will get stricture, urethral stricture after the operation. So we are using 550 thick laser. The laser we are using is luminous laser, 100 watt holmium laser, and the setting we use is 2 joules and 20 hertz, which will become 40 watt laser. So if you have a great laser like this, you can dust the stone and remove the stones with a dusting effect. Now, as you see, I use the technique of non-touch technique, which is called non-touch technique, which is you don't touch the stone and you will perforate it and you will dust it. It has 2 advantages. This first advantage, that the stones is small enough to come between your scope and the access sheath. You know, the scope is 7 French and the access sheath of this SMB is 14 French, so there is a big space to come this small dust, so you will not need to come out your scope unless the fragment is big. The second advantage is if the stone migrated to different areas, especially the ureter, that stone is very small, it's less than 3 millimeter, so it will not make obstruction effect, so the complication will be less and the patient will urinate that stones. Now I am taking the laser fiber back and near to me like a pencil. If you have the laser like a pencil near to your vision, you can control the effect of laser. But if the laser is far from you, you cannot control. You may burn the mucosa, and if it is so near to you, you may damage your scope. Now you can see I am pushing the stone against the wall using my access sheath, so the stone cannot run from me, and I'm treating the stone while I am inside of my access sheath. Treating the stone inside while you are inside the access sheath will prevent that accidental damage of mucosa. So two advantage. Advantage number one is stabilizing the stone with your sheath, and second advantage is treating the stone while you are inside your sheath, that the laser effect on the patient's mucosa will be less. Today I want to tell you that we are using today a different water pump with this backside of mine. Before we were using Hook company water pump, but today our water pump broken, so we're using different gynecological water pump, which is bad water pump because it is intermittent and not continuous. When the pump is intermittent and stop, start, stop and start, you will get less water, and when you get less water, the stones will not come with you. As you see now, the stone is not sucking with me. So my teacher every time tell me, don't suck. If you suck, you will take all the water with you and the stone will not come. You know, he tell me suck less to remove the stone. The SMB have three different sheath. The sheath one is 12 F12, which is 12 French, which is Tansen, or means single layer. The second one is 14 French, which we are using now, and it is double layer. The third one is 18 French, which is called ESMB, Enhanced Super Mini Pcnl. The enhanced SMB is 18 French, which is good for bigger stones, more than 3 cm. So what is the difference between single layer and two layer scopes, two layer access sheath? The difference is when you have two layer access sheath like the one we are using, the outer layer is only for water. Now you see the water we are connected to our sheath, so the outer layer only for water, and inner layer is to remove the stones, so there is no jamming during suction of stones. But you should careful that you don't press the sheath against the mucosa. If you press it, you will obstruct your water, so there is no water coming to you, and subsequently you cannot remove the stone. But the 18 French is good, that if you press under the mucosa, the stone will come to you with you, but the problem is sometimes the stone will go back because there is a jamming between the inner layer. It's only one layer sheath. In SMB, there is 3 generations that Professor Gohua-Sung invaded it. The generation 1 SMB, first generation, we put the water on the scope, so the vision is less because in the scope there is a large size laser fiber. And then the Professor Gohua-Sung changed the SMP to second generation SMP, which we are using now, that he banned to put the water on the scope. Our scope is now, we never connected water, and we connected the water on the sheath. So he made 2-layer sheath, so the water is going with a great pressure and your vision is enhanced. Now there is third generation, which is the difference is only on the scope. The scope who came now is called Hamushanjin. Hamushanjin or hamorenal scope is one scope for 3 different targets. One scope you can connect on 8 French outer sheath, and same time you can change it to 13 French sheath, outer sheath, protective sheath, and then you can change it to 17 French outer sheath. So it is only for one scope that you are using for 3 different purposes. If you want your scope to be 8 French, you will put the thin layer. If you want your scope to be a large working journal, you will put 13 French, so you can use it for ESMB, and that time you can use the pneumatic lithotropsy because you have a large working journal, and you can put your water in upper scope water inlet. Now we are putting on the sheath. That time you can put on the scope because you have large working journal. So the third one is 17 French that you will not use for SMB or ESMB, but you can use it for 22 French renal sheath, like clear Petra if you want to use suction, or the other sheaths. And same time you can use EMS for that scope. So it's good scope that you are planning to buy it and use it for different purposes. So let's come back to our surgery. Now we are treating the stone on UBJ area, and we are using the technique of chipping and dusting. Small fragments will come along my sheath, along my scope, and larger fragments I should come back to remove it with the section. And every time when you are treating the stone, it is recommended to stabilize the stone with your access sheath and treat it your scope while you are inside the access sheath. Now I should remove the stone to a safe area, safe haven, because the UBJ area is not a safe area. If you touch your laser on the mucosa, you may burn and get strictures. When we are using holmium laser, it cuts, it makes cutting effect with burning, so you will get bleeding also, and especially in renal infundibulum, that's the area of vessels, and if you get cutting effect, the patient will bleed and your vision will be less. But when you are using thulium fiber laser, which is a new laser who came to us, it make burning effect. It will not bleed, but it make a burning effect and make a deep burning, and stricture rate is more. So we carefully treat the stones without burning the mucosa. So these stones, we finish the surgery in half an hour, the lasing time, and we remove it 2.5 centimeter stone. The UBJ area 1.5 centimeter, and lower pole stone is 1 centimeter stone. So we prefer to use SMP subamine Pcnl for stones up to 2.5 to 3 centimeter stones, and it will take less than 1 hour. If your stone is bigger than 3 centimeter, it's not recommended to use SMB because it takes a long time. So that time you use ESMB, enhanced subamine Pcnl. So we use it up to 5 centimeter stones. We use it ESMB. And if the stone is bigger than 5 centimeter, it's recommended not to use this system because it takes a long time. So that time it is recommended to use the pneumatic or EMS and use 22 or 24 French Fresnel sheath. But in our center, we first look the stone Honsfield unit. If the stone is HU more than 1000 and hard stone like calcium oxalate, monohydrate, or cysteine stones, uric acid stones, this is a hard stones, which is HU is more than 1000. So these stones, it's not recommended to use pneumatic or EMS. EMS will not work on these stones, and the pneumatic will work, but it will make erosion on the mucosa, and this mucosa will bleed and your vision will be compromised. So we prefer to use, if the stone is very hard, we recommend to use SMB in our center. If the stone is more than 1000 HU, even if the stone is 5 centimeter or 6 centimeter, we use SMB. Now, as you see, we are treating stones inside the ureter, and when you treat stone in the ureter, you should be careful that you don't burn the ureter. So I very less use the lasering inside the ureter. So let us come back for our discussion. If the stone is very hard, we recommend to use SMB. So in our center, the longest surgery was 3 hours for a big stone, 6 centimeter stone, and the patient will not get any complications. Patient will not get any fever because the pressure inside is very less because of section. Now let's come back to our surgery. Now I came for lower pole stone. As you will see, the lower pole stone is in closed calyces. When you are treating a closed calyces stone, the speed of stone removal is very high. As you see, the stones, to treat stones in UBJ, which is a big area, renal pelvic, it takes on us almost 15 to 20 minutes. But now these stones that we are treating, which is 1 centimeter stone in lower pole, it takes less than 5 minutes to finish the stone, because you are in closed area, your water is very high, and your success of removing the stone is very high. Now my teacher is telling me that you don't worry to burn the mucosa because you are in lower pole. So he changed the techniques of fragmentation, that press the stone and press the pedal of laser to break the stone. So when we are in the ureter, we press the laser while we are in our sheath. But now when we are in lower pole, we don't worry for burning the mucosa and structure. So we take our time to to remove the stone. Now, as you see, the low ball stones is finished. Now we will go back to urethral stone to remove the urethral stone. So in SMB is very speedy and economically very less for the patient, because you don't need any disposable things to do the operation, and we never put nephrostomy, and our patient only the impacted urethral stone we put it DJ stent. If the patient having renal stone and the ureter have no mucosal swelling, we never put DJ stent. So we make Uguarhua, which means totally free of stents, unstented, tubeless Pcnl. But this patient we cannot do tubeless because he was having impacted urethral stone, so we put DJ stent. Only the patients with urethral stone we put DJ stent. Otherwise we put nothing. Now my teacher take it to treat the urethral stone. Now he's doing examination in upper pole of the kidney, and he's seeing that patient have no stones. We removed the stone, the laser fiber, and now we are preparing to put a DJ stent for this patient because of impacted urethral stone. Technique of putting DJ stent is different on conventional Pcnl. In this mini Pcnl, as you know, it's 7 French renal scope, so it will not go 6 French DJ stent, of course. So we first put the guide wire, and we back load. Now we come out the scope, and then we put the DJ stent on the guide wire, and then we use our scope as a busher. Now as you see, when we put the DJ stent, we push our scope with the guide wire, with the DJ stent. So our scope work as a busher. So we put the DJ stent like this. But you must be careful that you don't over push your DJ stent. Every time push and then come back, look where you are, and then push, come back, look where you are. Because if you are over push it and all DJ stent enter to the ureter, you cannot withdraw it, because your scope working channel will not allow to enter forceps. So you must be careful when you are putting DJ stent on SMB procedures. So I hope you enjoyed, guys. See you next case. Thank you for watching our procedure.